An introduction to critical care, presented by me, your host, Pat Nelligan. Very soon after patients arrive in the ICU, they have a portable chest x-ray. This is different from the type of x-ray that might be taken, for example, in the radiology department or the emergency room. It's essential if you are practicing critical care that you're able to look at a chest x-ray and establish several things. In this first tutorial, we're going to look at the different lobes of the lung, the anatomy of those lobes, and when they become collapsed or consolidated. Chest imaging in ICU, Part 1. In this tutorial, we'll discuss the basics of chest imaging, lung anatomy, and lung lobar collapse and consolidation on chest x-ray. A patient has been recently admitted to the ICU, and as soon as they're settled, a portable anterior-posterior chest x-ray is ordered. Why? When a patient comes into the ICU, we need to know several pieces of information about them that is not necessarily apparent on physical examination. How well the lungs are inflated, and lung volumes, and whether any parts of the lungs have collapsed in transit. We really want to know the position of hardware that we've placed, particularly the endotracheal tube to make sure it's in the trachea, nasogastric tubes to make sure they're in the stomach, and lines to make sure that they're in the proper place. By lines, I mean central lines. We're also interested, of course, in chest pathology because frequently our patients who are admitted to the ICU have been admitted with acute hypoxemia. So we're looking for evidence of pneumonia, aspiration, pneumothorax, pleural effusion, mucus plugs, pulmonary edema, etc. Let's start off with some anatomy on the chest x-ray. This is a standard chest x-ray. Now this is taken from the posterior to anterior perspective. I'll explain what that is in a minute, but this is the kind of x-ray that you'll see in an outpatient, someone in your clinic, or even someone coming into the emergency room that's able to stand in front of the machine. There are various things you need to recognize on the chest x-ray, so let's work our way around. The blob in the middle is the heart, and at the very top of this is the aortic notch. Then we have on the right-hand side the right atrium, the left atrium, which is difficult to see usually, and then on the left-hand side, the left ventricle. Now, superimposed on top of this and in front of it is, of course, the trachea and the carina. We have two clavicles, one on either side, and then a number of spinous processes that are very, very important with respect to determining the position of the endotracheal tube. We have a diaphragm, and we have a gastroesophageal junction that abuts the diaphragm, two spaces known as the costodiaphragmatic angles. We have our ribs, and then we have three different fissures that separate out lung lobes. There's a horizontal fissure on the right side and then two oblique fissures, one on the right and one on the left. Then, just adjacent to the carina and the heart on the chest x-ray are the hyla or the hilums of the lungs. So they're the basic things you need to look for when you're looking at a chest x-ray. When we do x-rays in the ICU, they are portable x-rays, and they're taken from the front anterior-posterior rather than from the back, and there are significant implications to this. This is the preoperative chest x-ray of a patient scheduled for cardiac surgery. It looks fairly normal. The postoperative chest x-ray looks absolutely awful, but you must take a couple of things into account before you go any further. The first is that this is a semi-erect picture, and the second is that it is portable. Comparing the two, the heart is larger due to projection and the mediastinum is wider. Also, the lung fields may look more opaque due to the images being compressed by the ventilator as it cycles and in the position that the patient is lying. The best time to take a chest x-ray is during inspiration. Now, if you have a patient down in the x-ray department and you say, take a deep breath in and hold it, it's very easy. In the ICU, it's all about timing, and a lot of the bedside practitioners don't know how to put on an inspiratory hold. So it's a bit of a lottery whether you get an inspiratory or expiratory film. Let's do some revision of the anatomy of the lungs. First of all, you need to understand that there are 5 lobes. The right upper lobe, the right middle lobe, the right lower lobe, the left upper lobe, including the lingula, and the left lower lobe. If you look at the volumes of these 2 lungs, the total lung volume when the patient is erect and on inspiration is about 5.5 litres. The right lung is bigger than the left lung because the left lung has to accommodate the heart. The right lung volume is 3 litres, the left lung volume is 2.5 litres. In the right lung, there is 1 litre in the right upper lobe, 500 mils in the right middle lobe, and 1500 mils in the right lower lobe. The right lower lobe is the biggest lobe. The left upper lobe is 1200 mils, and the left lower lobe is 1300 mils. Now, if the patient is caught in expiration, those lung volumes are substantially lower. The right lung loses 40%, as does the left lung. The right upper lobe loses 30%, left upper lobe loses 33%, but the biggest loss of volume is in the lower zones, in the right lower lobe and the left lower lobe, that nearly lose 50% of their volume. So erect and in expiration, the total lung volume may only be 3,300 mils. When the patient is lying flat and they're inspiring, compared to erect and inspiration, there is a significant drop in the volume by a few hundred mils down to 4,700. And again, most of the loss of volume is in the lower lobes. On expiration, there is a dramatic loss of volume overall compared to the patient who is erect. So this patient who is lying flat on expiration has remarkably reduced lung volumes, only 3,000 mils, and there's a huge loss of volume again throughout the lungs, but particularly in the lower zones. So if you have a patient lying flat in the bed, they're in exhalation and an x-ray is taken, this can be really misleading because it looks like they've a dramatic loss of lung volume. They're just in expiration. So we always try and take x-rays with the patient sitting up in the bed, holding their breath or having their breath held for them, being as erect as possible. It's important to remember that from the front, most of the lungs that you encounter are the right upper lobe and the right middle lobe, and of course the left upper lobe. The lower lobes are at the back. This is important in CT scans. Note that there's a slightly mysterious place in the left upper lobe that serves as the equivalent to the right middle lobe, and that is the lingula. This is named as such because it looks a bit like a tongue. On the x-ray, the lingula represents the part of the left upper lobe that abuts the left side of the heart. That's important if there's consolidation in the lingula, as we'll discover later on. One of the most dramatic things that we see on chest imaging in the ICU is collapse of 1 or 2 lobes. There are lots of reasons for this. Frequently, it's caused by mucus plugging. It's imperative that you can identify that lung lobes have collapsed because we often go after this with a fiber optic bronchoscope to fish out mucus plugs. In that case, you need to know which lobe is collapsed because you need to target that lobe when you're doing a bronchoscopy. When we talk about lobar collapse on chest x-ray, I think you should follow the Ds. Once the lobe collapses, several changes are apparent on chest x-ray. There is an increased density in the location of the lobe. The remaining lung is darker due to hyperinflation. The lung volume is diminished. Structures are displaced towards the collapse. Those structures include the trachea, the mediastinum, and the hilum. The fissure is displaced in the direction of the collapsed lung, and the trachea is deviated towards the affected side. Now let's look at a few examples. What do you think is going on in this picture? In this situation, you can see there is increased density in the right upper zone. The lower zone is darker. There is diminished volume, and there is a displaced fissure. This combination, along with tracheal deviation, strongly suggests right upper lobe collapse. Remember that the inferior aspect of the right upper lobe is constrained by the horizontal fissure, and so that when the lobe collapses, that fissure moves in a direction that is cephalad and inwards. What about this picture? Pause the video for a moment and take the picture in. Now, what are we seeing? The most important thing to spot is the increased density right here at the very edge of the right side of the heart and the diaphragm. The remainder of the lung is darker. The diaphragm is elevated. The oblique fissure is displaced downwards, and the mediastinum and the trachea are displaced to the right. Nevertheless, you can still follow the cardiac silhouette. The diagnosis is right lower lobe collapse. This is the area that we are interested in on chest X-ray. You will see a haziness abutting the diaphragm. This is a before and after shot. The area that is collapsed is under the triangle. What about this picture? Again, pause for a minute and concentrate on all the structures that you're aware of. What's quite apparent to me on this picture is that I can't see the right heart border. There appears to be an opacity that's triangular in this region. And this is diagnostic of right middle lobe collapse. It's that right heart border that disappears. It can be tricky to see, and it does require a trained eye. What about this picture? Again, pause for a moment, focus on the images, and see what you think. You'll notice that there is an increased density in the left upper zone. The left lower zone has increased opacity, it's darker. There is diminished lung volume on the left, and the fissure has been displaced upwards. The trachea has been deviated to the left. All of these things together suggest that this patient has left upper lobe collapse. And this is where you look for the pathology. In particular, you look for a density that obscures the aortic knuckle and increased lucency in the left lower lobe. What about this picture? The most important thing to notice on this picture, and it's such a common picture in the ICU, particularly after cardiac surgery, is that you cannot follow the left hemidiaphragm all the way into the midline because of the sail sign and loss of the medial contour of that hemidiaphragm. There is diminished volume and darkness of the upper lobe, tracheal deviation. This is all left lower lobe collapse. And again, the big thing to look for is that sail sign, typically seen in patients post-cardiac surgery. And you can see in this picture that you can't follow that diaphragm along due to left lower lobe atelectasis. Why does this happen after cardiac surgery? Probably because of the enlarged heart resting on top of the left lower lobe bronchus. Sometimes it can be quite tricky to try and get that lobe reinflated. And here is our sail sign. A few more pictures that you should be aware of are these. What do you think is going on here? Well, in this picture, you can't see any of the left lung. It's completely collapsed. There is complete atelectasis, and there is hyperlucency of the right lung. There is a diagnosis to be made on this chest X-ray. Have a good look at it, and I'll return to this in a subsequent tutorial. In this particular picture, you have atelectasis of the entire left lung, but also collapse of the right upper lobe. Again, there is a diagnosis. Pause on the video, see if you can identify it, and we'll discuss this in the next tutorial. What about this picture? Well, there are two things going on here. We have our sail sign in the right lower zone, suggesting right lower lobe collapse, but we also can't follow the right heart border all the way along. So there is right middle lobe and right lower lobe collapse. Finally, what about this picture? What's remarkable about this picture is how obvious the cardiac silhouette is. And the reason for this is the lungs are hyperinflated. There's so much gas there that everything's sort of dark around the heart and it stands out. And this is what you see in acute severe asthma with a lot of gas trapping and hyperinflated lungs. Radiologists use the term consolidation to refer to patchy infiltrates within different parts of the lungs that represent infection, for example, pneumonia, or fluid, pulmonary edema, or hemorrhage, or aspiration. Often it's very difficult for them to establish a precise diagnosis. It's important that you can recognize the difference between consolidation and collapse. Pause the video and look at this X-ray and see what you think. There is one finding that I really want you to identify. What do you think is going on here? This is right upper lobe consolidation. The airspace opacification has a straight lower border confirming that it's the right upper lobe. What about this picture? Remember, the right middle lobe abuts the right side of the heart. If you cannot see the right side of the heart, there's a problem. The problem is all this stuff here. So this is right middle lobe consolidation, obliterating the right heart border. What about this picture? There is dense opacification in the right lung, but I'm going to color in the abnormality. And there it is. And this is right lower lobe consolidation. I'm convinced that it's the right lower lobe because I can see the entire right heart silhouette. This is another case, believe it or not, of right lower lobe consolidation, and you can see some air bronchograms there as well. What do you think of this picture? This is left upper lobe consolidation. Now this is a picture I haven't shown you before. There is an abnormality on this X-ray. Can you identify it? What's abnormal here is the sail sign along the left heart border. This is a sign of left lingular consolidation, the loss of the left heart border. Finally, this is left lower lobe consolidation, and I've colored it in so that you can see it. If you try and remember these X-rays, you'll find it much easier to identify abnormalities when portable X-rays are put in front of you in the ICU. In the next tutorial, I will discuss identifying hardware on chest X-ray, ensuring correct hardware placement. I'll see you then, and I guarantee you'll learn something. So that was the first tutorial on chest imaging in the ICU, looking at different lobes, collapse and consolidation. Next time we're going to look at the hardware, that's the endotracheal tubes and the different lines that we insert. If you're enjoying these tutorials, please subscribe at CCM Tutorials or follow me at my blog at ccmtutorials.org. Introduce me to a few friends, leave me some likes and some comments.